Hello, everybody, and welcome to this session where, with great pleasure, I will be discussing two studies that were presented at ESMO that just took place in October 2023 with Professor Dirk Arnold for Hamburg, Germany. My name is Zorana Maravic, and I'm the CEO of Digestive Cancers Europe, which is European umbrella organization supporting patients with digestive cancers. Welcome, Dirk. It is a pleasure to be here with you today.
Thank you, Zorana, and dear viewers, colleagues, patients, friends, whoever. Happy to present some of the most recent research to you, discuss it with Zorana, and then I think we have the great pleasure of having, let's say, then also final conclusion, what really drives innovation and what really drives the first development of colorectal cancer treatment. So after the disclaimer, the obvious disclosures, but be assured that I will have the presentation without any further bias. I would love to start with you on the topic of rectal cancer. Rectal cancer is difficult to manage, as you all know. We have different therapeutic goals here in locally advanced rectal cancer. First of all, clearly, this is a curative situation and would love to offer cure to patients which are involved in this disease or which are suffering from this. And the second is we also have functional aspects. Quality of life clearly highly depends with the sphincter preservation and of course the good sphincter function. And having said this, I think you are aware that we have standards over the last year which have massively developed. About 20 years ago, we had the resection of the primary tumor as the mainstay of the treatment multimodality, followed by adjuvant chemoradiation and adjuvant chemotherapy. However, times have evolved, and we are now moving towards preoperative treatment. And as you can see over the last years, the preoperative treatment phase got longer and longer. Nowadays, if we follow this approach with the total neoadjuvant treatment, this means that we have a pre-operation treatment of about 4 to 4.5 months, including chemotherapy, chemoradiation, radiation, etc. And that's difficult for patients and also for the treating physicians to tolerate somehow that despite the better outcomes, we have such a long treatment period before we finally move to the resection of the primary tumor. However, over the last years, this escalation approach with more and more neoadjuvant treatment has slightly changed. And as you can see, neoadjuvant chemotherapy has been becoming a treatment option. And this is resulting from a clinical trial we have been presented at ASCO meeting this year. That's the PROSPECT trial. This is a large randomized phase 3 trial from the United States with more than 1,100 patients. And you can see that the two treatment modalities here, selective chemoradiation and chemotherapy versus upfront chemoradiation, let's say, resulted in the same outcome. So therefore, FOLFOX chemotherapy as primary modality became an attractive part of our therapeutic menu, so to say. And if you look specifically to the functional endpoints, and those are the data which have been published earlier this year, in June this year, also with a specific focus on overall health-related quality of life, as well as you can see on the right side, the functional scales, sexual function, bladder function, bowel function. We can see that chemotherapy is not only an attractive treatment option since it seems to have the similar efficacy than chemoradiation, we can also see that quality of life is better maintained with chemotherapy compared to 5-FU-based chemoradiation. And this is true in all treatment, in all aspects of quality of life. So I was very, let's say, grateful to see that also de-escalation of preoperative treatment has become an important goal of research, ensuring better quality of life. However, coming to this year's ESMO and coming to a second trial also addressing this question. So what is better in locally advanced rectal cancer without involvement of the mesorectal fascia, which is important? Is it the former standard neoadjuvant chemotherapy is it the former standard chemoradiation versus the new standard, like the prospect trial has shown, neoadjuvant chemotherapy? So it's more or less the similar question, but in a slightly different patient cohort. In this trial from China, 589 patients with locally advanced rectal cancers were randomized to receive neoadjuvant chemotherapy with capox for 4 cycles, compared to the standard chemoradiation with capecitabine. So chemorad versus chemotherapy. Primary endpoint has been the local regional recurrence rate. And to graphically show how this randomization was like, these were the patient group, locally advanced rectal cancers. Very importantly, the staging had to be with standardized and defined MRI to assure that the mesorectal fascia is not evolved. Then, if this would be the case, a different treatment strategy would apply. But these are many, many patients, and they were randomized to these 4 months of treatment with capox versus upfront chemorad, as mentioned before. This is already the outcome. And the outcome shows that if you look to the left-hand side, that the local regional recurrence-free survival rate at 3 years were very, very high. So first message, good selection of suitable patients. And here, as we can see, very high rates of local regional recurrence-free survival. But as you also can see in both arms, with seemingly without a major difference. So neoadjuvant chemorad versus neoadjuvant chemotherapy, the outcome are about the same. This is also graphically shown on the right-hand side. So the survival curves are very high and they are overlapping. So therefore, there's not really a difference in this outcome. And if you now take these 2 trials together, the prospect trial, which we have seen in summer, and now the convert trial, slightly different inclusion criteria, all MRI defined, but the same outcome, would say similar rates of local relapse-free survival in both arms, and also, as far as we can say, in disease-free survival. So therefore, the data from the prospect trials are confirmed by the convert trial in a different study population. Neoadjuvant chemotherapy seems to be a fair treatment option. And as I put it on the right side, what does this mean for the everyday treatment in the tumor boards we are attending? You're maybe invited to. This means for me that this procedure can already be discussed as a kind of standard of care for some, and that's not few, patients. So therefore, neoadjuvant chemotherapy has become an important brickstone in the whole wall of of local rectal cancer management. I would love to revisit with you a view into the future. And the future is maybe not only de-escalating standard chemotherapy or chemoradiation or substituting chemoradiation by chemotherapy. Maybe the future is also integrating new treatment approaches. And one of these new treatment approach is immunochemotherapy. And I would like to revisit this with you with another trial, which has been also presented at the ESMO meeting, also coming from China. So in this trial, they were, let's say, following a different path. And this different path was to modify both systemic treatment and radiation. The radiation modality here has been neoadjuvant short course radiotherapy, followed by immunochemotherapy, versus standard radiochemotherapy, followed by chemotherapy. So it's a total neoadjuvant approach, as we do say, in the standard arm. And the experimental arm means short-term radiotherapy and then intensified treatment in the systemic part. Or in other words, or graphically shown, 231 patients with these local advanced rectal cancers, low-lying, high-risk cancers, were randomized to either arm B, which is the standard, long-term chemoradiation followed by chemotherapy. And the experimental arm has been this short-course radiotherapy. This is only 5 days, 5 single fractions, Monday to Friday. And then this shortened radiation was followed by the immunochemotherapy. And the immunochemotherapy consisted of chemotherapy, capox, and the immune therapy with pembrolizumab, which is a PD-1 inhibitor. So therefore, outcome of this trial was, let's say, the pathological complete remission, because all of these tumors were removed surgically after this neoadjuvant treatment. And the findings were really surprising, because if we look here to the pathological response, we'll say the pathologist analyzed the specimen and they found in more than 39%, nearly 40% of patients, no vital tumor anymore when patients were undergoing the treatment with a short course radiation plus immunochemotherapy. By contrast, the patients which were in the standard arm undergoing chemorad followed by capox had a path CR rate of only 15%. This is also shown in the right part of this graph. Each of these vertical bars represents a single patient. You see them all in green means minus 100% of the initial tumor burden. So we'd say no vital tumor anymore. And you can see that there's 15% in the standard arm. But what we can see clearly is that here we see a better outcome, and really a clear better outcome for patients which were treated with this experimental treatment. Have there been any implications on surgery? Not at all. We can say that the surgical rate, the R0 resection rate, also complications after surgery were clearly the same. So no difference in terms of toxicity and or complications. So what does this mean? This TNT, as we say, the total neoadjuvant treatment strategy with this short course radiotherapy followed by chemoimmunotherapy showed a better path-CR rate than the standard arm. I would say the path-CR rate is quite outrageously high. It's difficult to believe, but that's what the trial has been showing. And we will see what the future and the readout of this trial also for longer endpoints, long-term endpoints will tell us. So what does it mean for the everyday treatment? For me, not yet a clinical consequence here, but this is highly interesting for the future and for the evaluation in future studies. So having these two new approaches, Zorana, what do you think? Are we really rewriting the story of rectal cancer new?
Thank you, Derek, for presenting these two very interesting studies. And, thinking about rectal cancer and also having in mind that more and more patients in the younger age are diagnosed with colorectal cancer, but more specifically with rectal cancer. I think that this approach is very important because it should give better quality of life to patients, which is we are aiming to, right? And we very often hear from patients that when they undergo chemoradiation, that they are, and then surgery, obviously, that they have certain side effects that they that last for a very long time. So I think these two approaches are very promising. I wanted to ask you, I guess for the second study, we will be waiting for the long-term survival outcomes before we can make any final conclusions.
I would say so, yeah. Let's say 40% of pathological complete response. That's difficult to believe, but that's what they did, and why shouldn't we believe them? However, we have to see whether this really translates into a good, what shall we say, disease-free survival and also overall survival. And we have also to see that these high rates are also observed in other populations, not only in the single trial in Chinese populations. Maybe we would like also to see this in Western patients, Caucasian patients, and with a long-term outcome. And notably, we have to think whether what we do see here, because it's immunotherapy, but it's immunotherapy mostly in MSS patients, we'll say microsatellite stable patients, where we did not expect to have immunotherapy to have such a great effect. But maybe that's somehow in a strange way synergistic to radiation, and we will have to see this, how this looks like in the future.
Okay, and I wanted to ask you for the first study, what would be the perfect patient candidate for for, in order to avoid the radiation? Because you said a few, not just a few, but certain.
It's many. Yeah, even many. So these are patients, excellent question, with stage 2 and 3 disease by MRI staging. They should not have low-lying disease within sphincter being infiltrated or sphincter being at risk. Then they do need radiation. So the sphincter should be free. And also, very importantly, the mesorectal fascia, which is an anatomic structure surrounding the rectum. And this should be also not involved. That's really critical that this is free. But this can be defined by MRI. I personally would say it's about, at least in Germany and in the Western European countries, as far as I see, 40 to maybe 50% of all patients follow under this category. So therefore, for them, neoadjuvant chemotherapy could be a treatment alternative.
Okay, and what I can only conclude from what you said is that it is of utmost importance that this type of patients are being treated in the centers of excellence when there is a needs to be by surgeons, by oncologists, by radiotherapists, and they need to be properly assessed in order to receive the best possible treatment for them and also to get the best possible outcomes.
I fully agree, Zorana. I think that's the key point. Presenting these patients at centers, at least for a second opinion or for definitive treatment, is clearly of utmost importance here.
Thank you, Dirk. I think that I have no further questions on these two studies. It was a pleasure discussing them with you. And I hope to see everyone next year.
Thank you.